All right.
Morning.
Good evening, everyone, and thank you so much for joining us for this session. It's part of our series of virtual open houses so that we can get to know all of you a little bit better and also really take you on a deeper dive into some of the parts of our curriculum. My name is Ted O'Connell. I'm the program director at the Kaiser Permanente Napa-Solano Family Medicine Residency Program. And I will say we really do appreciate the time investment that you're putting into this session, and hopefully you'll get something very worthwhile out of it. Today we're actually going to be covering two topics. One of them is integrative medicine, and the other is our OB experience. I just want to be very explicit that those are two separate topics. I think the way we originally sent it out, it looked like it could have been integrative medicine in OB, but we're actually just talking about two pieces of the curriculum today. I will serve as host. We have two great facilitators joining us. The first is Dr. Sarah Jones. She is a member of our core faculty, practices outpatient, full spectrum family medicine, helps to run our women's health procedure clinic and precepts there, and works up on labor and delivery. In terms of her academic oversight, she directs our academic half day that is every Thursday afternoon. She has oversight over our clinical skills month, which is July of each academic year. And she's the lead for our integrative medicine elective, which is run through the Integrative Medicine and Residency program through the University of Arizona. And she'll tell you a whole lot more about that. And she has other roles as well. So I don't mean to skip any of them, but I don't want to make our introduction too long. Dr. Gabe Flaxman is one of our core faculty and has been with us since the launch of our residency program. He does full spectrum outpatient family medicine, also helps to work in both the procedure clinic and our women's health procedure clinic. He works up on labor and delivery and is actually fellowship trained in obstetrics. So when he's up there, he does operative obstetrics as well. And he has oversight of our entire women's health curriculum. So I will hand this over first to Sarah there, and then when she's all done, Gabe is going to give us an overview. And the idea here is to give you an overview of each piece of the curriculum and then really move into Q&A. So I encourage you as we go along, make liberal use of our chat function. We will try to answer some of those questions on the fly if they're short, and if they require more attention, then we'll wrap them into our Q&A session. So with that, Dr. Jones.
Good evening, everyone. It's so great to see you. I'm seeing a lot of familiar faces from some of our other Zoom sessions, and it just makes me so happy. So in any case, I wish we could all be together, but this feels kind of like we're together, and we'll take it away. So thank you for that very kind and generous introduction, Dr. O'Connell. I am going to try to share my screen here. So let me know if you see an elephant on a ball.
We see it, Sarah.
Okay, perfect. All right. So I'm actually not going to ask a lot of questions, which would be my usual style just because of the format. But again, as your questions come up, please feel free to go ahead and put them in the chat. So as Dr. O'Connell said, I'm a family physician, and pretty early on in my career, developed an interest in taking what I already consider a very holistic approach to medicine that family medicine is, right? We do cradle to grave, womb to tomb. We're very prevention oriented. And we focus on the biopsychosocial model of healthcare, and it is really comprehensive. And what I realize is that there are still complementary approaches to health that I needed to learn, and that our patients are tapping into themselves, either because they are part of their cultural norm and upbringing, or because they just want a more natural or holistic approach to traditional medicine. And so I was introduced to the University of Arizona longitudinal integrative medicine and residency curriculum, actually when I was a faculty at another program, and really it just resonated, and was very thankful to have the support to bring it to our program here at Napa-Solano. So I personally am also trained in medical acupuncture and more recently board certified in lifestyle medicine. So really am doing everything possible that I can to bring as evidence-based approach to health as possible for my patients, and then trying to share as much knowledge with the residents along the way. And have also been very thrilled to learn from residents who've also been exploring these areas themselves. So what is integrative medicine? You know, it's in the past, it's been known as a bunch of other things like complementary and alternative medicine, alternative as opposed to like in juxtaposition to Western medicine. And really, I look at integrative medicine, and I borrowed this from the web, and I liked it. It balances the advances of Western medicine with the best in holistic therapies, some of which have really good evidence. There are a lot of really good studies out there. And then I think we can acknowledge that there are modalities that that anecdotally are helpful or therapeutic, and maybe don't have the very best evidence associated with them, but also don't have drawbacks. So one thing I'm thinking about right now would be something like adaptogenic teas or adaptogens, right, which are typically plants or herbs that are found in nature that can promote all sorts of things. But you know, I'll mention like ashwagandha, which is good for calming. It really has a neutral effect on the system. So if you're worried about liver toxicity or renal toxicity or things like that, really it should have none of that, and yet still have some beneficial effects for patients. So again, there's some evidence for there's more evidence for some modalities than others, but I think it can be safe to be open to at least learning more about these modalities, and the curriculum does allow for that. So I like this image because, again, it really takes us back to our why as healers. And there's room and a need for all of us, right? So we need specialists. If you look at the tree, the phenotype, the manifestation of the seed that's in the ground, right? So that as things pop up, symptoms develop, a cancer grows or develops, whatever the case may be, we need a valid therapeutic approach to minimize and take care of those symptoms. And at the same time, can we think about what are the root causes? And are there things that we can do to either prevent the manifestation or the development of disease? Epigenetics sort of even change the way genes are expressed through lifestyle, right? And then consider what are the environmental factors that also influence the manifestation of disease versus really promote health and keep people doing what they want to do, when they want to do it, and how they want to do it. So, you know, a little bit of the nitty gritty. You know, the curriculum that we use that I think is probably the best established nationally is the Andrew Weil University of Arizona Center for Integrative Medicine. They offer a 200-hour longitudinal integrative medicine and residency curriculum, and it's quite rigorous. And I'm delighted I just put a laundry list of names here that in the 3 years that we've been doing this, the majority of graduates have actually taken this elective. And the way I've urged them to think about timing themselves through the elective is to actually take an elective block, a 2-week elective block, to pick one area in integrative medicine that they really want to develop. So it might be yoga, it might be movement or being outdoors, it might be cooking, it might be herbs and making tinctures. And really you craft your elective time to really get really good at that and go through some of the coursework, and then spread out the coursework, the additional 200, you know, the rest of the 200 hours throughout your rotations, and then just kind of be strategic about rotations that might be a little bit lighter in terms of call responsibilities or clinic responsibilities, and go ahead and weave in the rest of the curriculum there. And everybody who signed up has been successful in completing the course, and we currently have 4 enrolled. 1 senior, 2 second years, 1 senior, and then 3 second years. This just gives you a snapshot of the many, many different areas that are covered in the curriculum. And then if you were to go to the website and click on any of those plus signs, there would be about 10 to 12 topics under each one. So this is where the 200 hours is. And to the extent possible where evidence exists, those citations are woven into the curriculum. I also want to share that within our own organization, within Kaiser Permanente, we have a pretty well-developed, you see here on the website, complementary and alternative care services. So there's a site called Choose Healthy, and this actually allows our members to go on and find out, hey, who in the community does massage therapy or chiropractic therapy or acupuncture, and to be able to access those typically at a little reduced cost because they may not be fully covered by their health plan, but at least it's an acknowledgement that this is something that patients want, and they want to make it available and not sort of like shun it or poo-poo it. And similarly on our, I thought it was on here, but in any case, we actually have access to the natural medicines database, which usually is a subscription that costs a fair, you pay a subscription for it, but our organization makes that available to us free of charge. So when patients come to us and we're asking about medications or what therapies they've tried, when we can ask about supplements and herbs and have a reference that's evidence-based to look into it. Or when they say, what do you think about, ginkgo biloba for memory? Or what do you think about ginger? What do you think about whatever the case may be? We don't necessarily have to be the expert, but we have a resource that's available to us. We can say, I'm not sure, but I can get back to you. And then there are actually patient handouts that we can share as well. So again, I just appreciate the acknowledgement that our patients are utilizing other supplements other than what we would typically prescribe, and we can learn about them ourselves pretty easily. So one of the more robust aspects of integrative medicine that really resonates with our residents and me is food, or food is medicine. And you might recognize this quote from Michael Pollan, who wrote The Omnivore's Dilemma, as well as other publications. But if it came from a plant, eat it. If it was made in a plant, don't. Little catchy play on words there. And to that point, we actually have in the San Francisco site, there's a physician who's a director of culinary medicine. She has her own cooking kitchen. I might be a little shade of green with envy that she has that. I think they have one in South Sacramento now as well. I am doing everything I can to see what we can do to have that in Napa-Solano. But in the meantime, what we do with our residents is, and then actually this is a website for our patients. I actually send them there for plant-based recipes and such. But so just more resources. But what we do with our residents is we, on an annual basis, do a food as medicine half day. When it's not COVID times, they come to my house on a Thursday afternoon in December, and the residents that are enrolled in the integrative medicine curriculum, they are in charge of coming up with a menu, usually a plant strong, if not completely plant-based menu, giving it to me. I then purchase the goods as locally sourced as possible, and then they all come and then they prepare the food. That's washing, that's dicing, that's mixing, that's using the blender to do seasonings and sauces and all this kind of stuff. And then while the food is baking or roasting or whatever the case may be, we typically would then have a guest speaker. And we've had people talk about medicinal plants. We've had people come and talk about microgreens. Last year we made elderberry syrup just in time for flu season. So this is just a picture of some of our residents from years past, and delicious food. And then this is us in a circle in my living room having a discussion. And we invite faculty that are able to make it. We invite our public health team. So it's just really lovely time together. This year with COVID, of course, we're not allowed to, oh, and then this is just a picture at our rooftop garden in Vallejo, where our residency is. So again, trying to locally source our own greens to the extent possible. But this year, because of the pandemic, with the integrative medicines residents who were able to participate, we did a Zoom dinner, cooking dinner, Plant Strong. And so here's just some images of the menu that we put together. And then one of the residents came to pick up the bags that we assembled. My family and I assembled for them. And then we got on Zoom. And there was actually another resident. It was five teams total. And we made this delicious food together. So all Plant Strong and delicious and hearty with leftovers for lunch, which is practical when you are working busy rotations. So that is a tangible way that the integrative medicine is incorporated into our lives as a residency. And then I'm just going to end here. And this is actually shared by a colleague from the University of Arizona. And I can just tell you, the University of Arizona has been so generous in sharing resources for just how to stay well during this pandemic, how to stay well from a physical standpoint, and how to stay well emotionally. And again, this is pretty germane to our specialty as family medicine physicians. And we can always be more comprehensive in our approach in integrating mindfulness and gratitude, as well as movement and healthy fuel to keep us strong as we're taking care of our patients. So I will end there. And
thank you so much, Sarah. That was outstanding, and I agree with Pablo. You're making me hungry. I'm going to suggest that we pivot to Gabe's presentation and hear about OB, and then show what great whole person family physicians we are, and take questions from both the OB experience and the integrative medicine experience at the same time instead of going sequentially. I hope that works for everybody.
Okay, can you guys hear me now and see my OB curriculum slide?
Yes, we can.
Okay. I also got very hungry, and you have to pardon me as I'm snacking as we go. And hopefully we don't have too many interruptions from a rambunctious 5-year-old or our COVID puppy. So I'm gonna say thanks, Sarah, for those slides and for kind of relaying some of those pictures. It's great to see all the graduates and all the residents in that setting. My slides are going to be a little bit drier, I have to warn everybody. And I'm going to try to go quickly with room for questions. So I figured, since you're interested in OB, I'm going to give you the orientation that with some modification that the residents get in July. Let's see. So our curriculum overview for OB is that we do 8 weeks as interns. It's 4 weeks in the first half of the year as a block. And then the second half of the year, we recently, about 1.5 years ago, split the rotation to do 2 weeks alternating of OB and 2 weeks of newborn. And so that goes on for 8 weeks, and it's kind of a maternal child health rotation. The value is that it breaks up OB time, which can be long and tiring, and has the potential to feel a little bit more isolating, as there's only one resident on L&D. It also gives the benefit of kind of allowing OB concepts to percolate in a lower pressure environment. You're up on postpartum rounding. You may be doing a transition with the nursery or the pediatrician at delivery, watching one of your colleagues do a delivery, and you get to learn without the pressure of actually thinking about the table or the next steps. So this is the second year we've done this, and so we haven't actually started with this class of interns, but the current R2s enjoyed it quite a bit. And I think it's been a really nice transition, both for resident wellness and fatigue mitigation, as well as I think it's actually optimal for learning. In the second year, our residents do 2 weeks of nights And then they do weekend coverage and electives. And the R3 is weekend coverage and electives. And then we have continuity care in the Family Medicine Center, as well as centering pregnancy. You can see it's kind of a intern heavy year, and then it is more of a maintenance of skills later. And the idea is that we recognize that family physicians and you all have interest in all sorts of family medicine. And we wouldn't want to scare somebody away from our program who really wants to do OB, but isn't going to do a fellowship or do labor and delivery afterwards, and therefore chooses not to go somewhere where there's 6 months of OB as a second and a third year. So it's very foundational in the first year and then maintenance later. The other thing that's really unique about our program is that it's very labor management based. So when you're on OB, you're the only resident on OB. And what that means is it's you and the non-operative provider, which is either a family doctor or a midwife, and the operative provider, which is mostly an OB-GYN, myself, and there's one other surgically trained family doc. And your schedule, I'll show you in a couple slides, is all deck time. So it's basically labor management all day, every day, with the exception of a clinic and some protected time to work with the faculty in terms of didactics or skills workshops and stuff like that. Because it is one resident, we have a self-directed learning module, and I'll show you a little preview of that. We've moved to Canvas, which some of you are probably familiar with from med school. It's a little learning curve for me, as I'm not that techie. And we have this longitudinal maintenance of skills, and then we have plenty of ability for extra training. We have a whole other hospital that residents don't rotate at that have the same doctors and midwives working at. So people want more, we have more. Our focus is, this is if you kind of graphically inclined, so this is the components of the curriculum. In our clinical skills month, we have an all-day introduction to normal labor and delivery, an all-day workshop with prenatal care and ultrasound. In the middle of first year, we do also, which many of you are familiar with. If you're not, it's called Advanced Life Support and Obstetrics. It's a nationally recognized AAFP program that's evidence-based and widely utilized. There are many hospitals that require all staff, family docs, OBs, and nurses to take also. Sarah's actually was on the national advisory faculty, and we've taught it in our site for years. We've also taught a trainer program for people that want to become also instructors, which we hope to do again as the COVID dust settles. And then on rotation, we have this Monday protected time where I work one-on-one with the intern, kind of going over whatever clarifications or models, working with the mannequins or talking about concepts that are getting confusing if you talk to 3 different people who say, well, this is how I do it. We have some readings, and then throughout the 3 years, there's continuity care for prenatal care, and then centering. We have some didactic time, and we do workshops. Try to do mostly case-based workshops, and we could probably fill many, many more hours with stuff we'd love to do. And then, like I said, more elective time. I think we'll skip that one. We have a pretty good lactation service with, currently I believe there's 3 lactation consultants, and all our nurses are lactation trained, and we do some work with them. Our main lactation consultant's a little shy, won't come do a lecture with the residents, but she's awesome with the residents who are rounding with well babies or on postpartum to kind of help with teaching. And we have had a couple lactation electives for those that are really interested. In fact, one of our graduates is a certified international lactation consultant, and is considering working in addition to her other work in that vein. We talked a little bit about also, for those of you that want to see, here's kind of the layout of the month. So you basically Monday mornings on labor and delivery, and then we do some workshop, and it's kind of like whatever you need. So the first time it's usually how to C-section assist or reviewing normal delivery and lac repair and suturing and stuff like that, depending on what somebody needs. The second week we might do more, procedural stuff, postpartum hemorrhage or shoulder dystocia, and then you go to clinic in the afternoon. And then Tuesday, Wednesday, Thursday, Friday is all labor and delivery management. There's a couple, so it's 2 Saturdays, and the chiefs make the call schedule. So sometimes it's every other, sometimes it's 2 in a row and then 2 off, but that's usually, decided by residents. And then this is kind of what the day looks like. You come in the morning, do some postpartum rounding, meet all the patients, take care of all the patients all day, do some learning as you go, and then sign out again as it's 7:30 at night. I think just for your structure, those of you that aren't familiar with Kaiser, it's a little different. So you may have done your OB rotation somewhere where there's like 600 deliveries a month, but there's 5 private practice groups, an MFM group, family medicine residency, an OB residence, some midwives, and a couple of like solo practitioners that all come to the same hospital. And the nurses figure out who's on call for that group, and then they call that person's team. And the residents are kind of at the whim of who's on call. In our system, it's one team. So if there's 3 deliveries in one day, then in a couple hours you might be busy. If there's 10 patients in labor, we'll call a backup doctor from the hospital to come help. But there's no calling this attending at home and worrying that it's bedtime or dinner time or any of that stuff. It's in-house people 24/7. We VBAC whoever's VBACable who wants to. We don't have to worry about getting anesthesia who has to drive in from somewhere, any of that stuff. I think I talked enough about continuity. We really do want to maintain the idea of continuity care. We're getting people, centering pregnancy was robustly established and doing really well, and then COVID kind of adjusted everything. And we're just now in the process of rolling out virtual centering for a couple of sessions, and then we're probably going to transition to a hybrid as we figure out how to socially distance centering groups, because it's just been really great for members, patients, families, and residents. And so we're hoping to get that going again. I have a couple groups where the group is now in their second round of pregnancy, and they seem to all be delivering at the same time, and they're all friends. And one of their labor plans was to drop the kid off at the other one, or doula for each other. And it's pretty cool to see that it's really sticking. So I'm going to skip over that and then show you guys. Let me see if I can make this a student view. So some of you may be familiar with Canvas. But this is what we've worked on, is transitioning our reading. So we have this resource that is for our residents and our faculty. And what you'll see is the goal is it's a combination of kind of nuts and bolts. So here's like phone numbers and call room numbers and stuff like that for the curriculum, as well as some required readings and expected readings for different modules. And so we have required readings that are usually AFP articles, and then we'll have links to a video or put a PowerPoint in here. And this is, in the perfect world, this was going to be rolled out and seamless, and we realize it's just going to be constantly evolving. But the idea is this will include your board study, your point of care reference for when you're walking down the hall to triage, as well as a reference site for a deeper dive into the primary literature. And we're pretty excited about it. It's been much easier to use once I figured out how to set up a Canvas. So I'm going to stop talking. I'm going to see if, I don't know if there was questions, or if Ted or Matt, if you guys want to join in, or if I can read the chat, or what's best.
Thanks, Gabe. I think what I'd like to do, I'm going to kick us off with 2 questions, if you don't mind, just so that we get it rolling. And then I do see some questions coming in from the students. So I'll just moderate that and ask our applicants to go ahead, if you're comfortable, to go ahead and ask those questions as we call your name. But 2 questions that I'll kick off with, one for Sarah and one for Gabe. Sarah, I think it's worth telling everybody a little bit about the also work that you've done in Honduras and elsewhere. That was discussed in the open house that we did on our global health curriculum. But I think there's so many of these things that weave in and out of different pieces of our curriculum that's worth mentioning. And then Gabe, I get a lot of questions during interviews about OB and the experience and the volume, and do our grads, are they prepared to go out into practice and do, prenatal care and labor and delivery as family physicians if they would like to? What does the overall volume look like? Are they prepared to go to an OB fellowship if they want? And do we have any grads who are doing OB in their careers? And I know I kind of layered like 3 or 4 questions in there, but I think the more we can answer these common questions that come up during interviews, the better for all of the students who just joined us. So Sarah, if you don't mind, kick us off with the also in the global health piece.
Oh, thank you. My pleasure. So, yeah, so the Advanced Life Support and Obstetrics, have you all heard of it? Some of you, yeah. So it is, as Gabe said, it is pretty much universally taught across the country. I've been teaching it for 20 years from coast to coast and in Hawaii. So, and have been very thankful to have the opportunity to teach it in Ethiopia, in Guatemala, and in Honduras. And I mean, talk about, just hands-on, what a great course for hands-on skill sharing, knowledge sharing, and really validation for the maternity care providers in those, in those settings that we all have this common goal of safe deliveries. But in any case, I've been particularly delighted to have residents participate in teaching. So as Gabe alluded to, we have not only taught the also provider course, we've also had the opportunity to teach an instructor course and then take those instructor candidates to teach locally in our program, but also internationally. So, give a man a fish, you feed him for a day, teach a man to fish, you feed him for a lifetime. And I think really, as physicians, we are always in a teaching role. And then whatever discrete skill sets that we can take at home and abroad, even more so. So I'm just thankful to have the support of a program to give time to do those things abroad.
Awesome. Thanks, Sarah. And then Gabe, if you don't mind commenting on volume and preparation for practice and fellowship and what our grads are up to.
Okay, I'm going to try to get it, and just don't feel bad if I miss something, just ask me again. So it's a good question. I realize I probably should have put the numbers in, both delivery numbers and what our graduates are doing. We're an established program, but we are still newer, and with 6 per class, we don't have, a decade of track record of what people do. We have currently 2 of our graduates who are working as attending physicians in our own hospitals on labor and delivery. I think that is a testament both to our training program and the collegiality we have between family medicine and OB. So one of them does labor and delivery shifts as a non-operative provider and works on HBS, which is our inpatient service. And so that's her job. She also does some peds. I don't know how she does all of that stuff. The other one is a family doc, took a panel in our department and does OB calls. She was doing some clinic in women's health. I think now she's only, I don't think she's doing clinic anymore, but does OB call in the non-operative role as well. In addition to the 2 of them, and they're each in a class, so that's like 1 out of 6. I don't know, 15%, I guess, ish, per class graduates and does OB. There was a graduate in the first class who actually did an elective at a freestanding birth center in Arizona, where she's from, and was contemplating being there, expanding their medical role and doing peds visits and labor and labor management in the birth center. And I think for family reasons has opted not to move back to Arizona just yet. But I think she's really, really missing it and wanting to. In our our most recent graduates, there was nobody that was particularly OB interested. They were all excellent on labor and delivery. So none of them took a job then. And then we just found out that one of them has got the bug. And so she's starting to take OB call at one of our local hospitals in Oakland, Alta Bates, which she works at one of the FQHCs, or Federally Qualified Health Centers in Oakland. So she's starting OB call in a month or next January or whatever. So I'd say on average, if they stay with OB, that's kind of better than the national average of graduates of residency in that 15% doing OB. all of our graduates at the end felt comfortable managing low-risk labor independently and theoretically doing a low-risk delivery independently. I say theoretically because there's always somebody there. I mean, sometimes I may have my gloves off and taking pictures for the family, but I'm there. So they never actually are doing an independent delivery other than the accidental precip in the elevator or in triage or something. Every single one of them is a competent first assist in a C-section, and I have no problems with one of them being my only assistant unless it's a, very complicated patient or C-section. And the goal was manage high-risk labor and consultation, and they are comfortable with that. So in terms of actual numbers, it's OB, and so it can be quite wild. I recall, I think Chloe had 40 deliveries in her first month as an intern, and a couple of graduates had like 40 vaginal deliveries in their whole year, and you're like, how is that possible? But that's just kind of how it goes. I think we're looking, and Ted, correct me if you have the numbers available. I think it's usually around the like 60 to 100 vaginal deliveries. 20 to 40 C-section assists, probably more in the lower unless somebody's really interested. Sometimes people ask about primary C-sections. We've had one person who was considering a fellowship who, when she said she wanted to do a fellowship, the OB hospitalists universally were like, yeah, let's train her. So she started primarying C-sections, and then she ultimately opted not to fellowship. And we have a current second year who's highly considering fellowship, and he's done a bunch of primary C-sections already as a second year. So we have no interest in like getting every single family doc to do C-sections as part of residency. But for the people that are going that way, the kind of feeling is, well, let's make sure we send them strong. So that was graduates. That was pretty vague on numbers, and I'm sorry about that. That was skills afterwards.
That's perfect. You actually got them all, and those numbers are right in line with what I've pulled from the data sets and reported to the ACGME. And I would just emphasize that those numbers are reflective of kind of baseline experience. And there's always, if you really want to use elective time or trade shifts with people, there's always opportunity to get more experience there. And then Sarah dropped a thing in the chat that there are also other residents who aren't doing labor and delivery who are doing prenatal care in their practices. And there's actually quite a number of them. So just to kind of round out the prenatal women's health experience.
Yeah. Ted, can I add
Yeah.
two things? I realize one is from the chat, and one is that I just forgot to say at the beginning. So when we were creating these open houses, we were kind of, trying to figure out what made the most sense. And we somewhat arbitrarily separated women's health and family planning and GYN care from OB. So we had a talk before, but if anybody has questions at the end and we have time, we're happy to answer those questions as well. And that's a totally arbitrary separation that had mostly to do with Sarah and my schedule. The other thing, I saw a couple things about MAT and addiction and pregnancy, and it's a very interesting question that people are posing. In the last couple of years, most of our faculty, if not Ted, if not everybody, has gone through and gotten X-waivered in terms of faculty. In our system, the way it currently works is patients who are on maintenance therapy are seen in our addiction medicine department, and their prenatal care is managed by our perinates. That's somewhat historical before there was a high volume of either methadone or buprenorphine. Our perinates don't particularly have a passion for taking care of this demographic of patients, and there's this complicated algorithm for how to make sure the mom meets a pediatrician who she feels comfortable with because she doesn't want to be judged for her maintenance therapy. And so we kind of said, hey, knock, knock, like, we can take care of all of this and you don't have to have this weird handoff thing. And we haven't done it yet. Some of it, I probably sound like a broken record with COVID excuses, but it's a big project to take on, and it would be great to have a resident who was super keen. Our current chief was really instrumental in getting MAT training as an emphasis for the residency, and so all the faculty did it. And that's the next step. So if there's a resident that's prenatal care, prenatal or OB oriented who's really interested in this. I could see that being a win-win-win, because I think the perinates would love that, and I think the addiction medicine team would appreciate it, and I think peds would be happy as well.
And we're going to have to nurture that, because I want to keep expanding our MAT and Suboxone prescribing. So that's great. I see a question. I'm just going to kind of go in order to be fair here. Gabriella, do you mind posing that question so that everybody can hear what was on your mind about vitamins and minerals and supplements?
Sure. Hi, I'm Gabriella. So I had a question for Dr. Jones about, I've seen a lot of patients who will come in taking like 10 plus vitamins and supplements that were not prescribed to them. I'll ask like, oh, like who told you to take this? And they're just like, it's recommended. By who? It's recommended. And I was just wondering if the curriculum has any guidance on how providers can help patients maybe stop taking so many supplements, some of them that might be dangerous, and how to kind of navigate those waters and figure out, how to make things cheaper for patients.
Great question. So I would say that the curriculum doesn't necessarily address how to get people off of supplements, but rather provides information on various supplements, and then therefore a more informed way of talking with patients and saying, oh, let's review your medication list. Is there anything else that you're taking? Okay, would it be okay with you? Oh, I'm not so familiar with those things. Is it okay with you if I do a little bit of research and then circle back with you? And then depending on what you find, or you may already have the knowledge, then enter into those conversations. And most patients, I find, are so thankful that we're willing to take the time to invest, learn, and then circle back. And then ultimately, of course, it's their decision. But I think really the curricular approach is really more just us getting more knowledge and familiarity. And if it's okay with you, Ted, I'm on call tonight. So I need to get to the hospital. It's a baby catching night for me. So I will just take a few other of the integrative medicine related questions, if that's okay, from the chat, and then I'll just say goodbye for now to the group. But I saw a question, and these might be out of order, but a question about rotating with other practitioners in the community. And I would say that we empower our residents to set up their electives however they want to. And so I don't personally have a lot of well-formed relationships in the community because of my own need for balance in life. So that's not an excuse, it's just a reality. So I don't have a whole lot of people outside of who we have available through KP, which are our acupuncturists. There are some chiropractors that are that patients can go to, that I suppose could be a place where residents do electives. There was a question about, do DOs have an opportunity to do OMT in their clinics? We actually have a faculty who is a DO and does an OMT clinic, and oftentimes has residents with her. Again, that has been curtailed because of the pandemic. Understandably, but absolutely that's available. One of my colleagues in Vacaville is an OMT and has a DO clinic and takes consults. So there are certainly avenues, again, within our system for your own practice, if that's something that you're trained and want to continue, or just want to witness. And then I will take, Gabe, if it's okay with you, I'll just take the one question about OB ultrasound. So our OB ultrasound, there's a question about how familiar do people get with doing ultrasounds. I would say pretty darn familiar. So in the clinic, you are going to do dating ultrasounds. We do miscarriage management. So of course you need to be comfortable with an ultrasound in that setting. And then of course on labor and delivery, it's very nuts and bolts to assessing women who are presenting with all sorts of chief complaints. So whether it's looking at placental location, amniotic fluid, heads or tails, right? So there are a cervical length. So there are a number of applications that I'll be doing tonight, I'm sure, and that our residents do when they're evaluating women in triage and, of course, in their clinics. So I hope that answers that question adequately. And I'm just going to say goodbye to the group for now. Hopefully we'll meet again in some format.
Thank you, Sarah,
Sarah,
for joining us, and everybody who interviews will have Dr. Jones's email along with everybody else's. So if you have questions, thank you, Sarah. Have a good shift.
All right, thanks. Bye, everybody.
Bye.
I see a question here for Gabe from Adrian about C-section rates. Adrian, do you mind posing that question?
Hi, yeah. So I was curious, you had talked about there being a heavy emphasis on labor, I guess labor and delivery, like keeping the residents there with laboring patients. And I'm wondering if you've noticed, or if anybody's measuring, if that has an impact on C-section rates, especially since we know that the US national rate is so high. I don't know what the rate is at Kaiser, but.
It's a good question. I don't think the residents have any impact on the C-section rate, if really one way or the other. Because we have in-house team, we don't particularly need a resident to be there. This is not a center where you have a doctor who may have a brilliant mind and written tons and tons of textbooks but doesn't know how to order anything or hasn't actually done an exam or a delivery in a decade. All of us are completely fluent in our electronic record and practicing clinicians. And so the resident might, I would think if anything would decrease the C-section rate just by asking questions, but we're never in that place where you're like, oh, my shift's over and if I don't deliver this patient, I'm not going to get paid for my time, or I don't want this patient to be on the board for my colleague. We're there on a scheduled system for the call takers. So if I have 7 deliveries in a 24-hour shift, I'm going to be really tired at the end of it, and I'm going to be no better off financially than if I have no deliveries in 24 hours. And so in that sense, that we have a system that's set up to really do right by patients. So I don't think there's much effect on C-section rate. And the idea of labor management is some programs will have 5 residents on an OB rotation at once, and they'll all round in the morning, and then 3 of them go to clinic, and one's doing labor management, and the other one is on nights, and they're just getting off. And so while you might have 6 months of OB, you're only doing deliveries every 4th day, or you do a week of days and then a week of nights or whatever, but there's a big team. In our case, you have 1/2 day of clinic, of your continuity clinic in family medicine, and the rest, a little bit of protected time with me for didactics. But the rest of the time is managing laboring patients. If those patients need a C-section, the resident is going to go to help with that C-section most of the time. If it's a true crash under general and it's your first day and the patient's, has platelets of 40 and a BMI of 70, I'm not going to have a resident assist me for that as their very first C-section. But for most of the time, we're going to have residents first assist. So you have that continuity with your patient. The other nice thing about the continuity is then you see them next day and the day after that. So you get to see the kind of natural course of postpartum and recovery, and also triage and latent labor, not yet in labor, go home, come back later, maybe a little bit in earlier labor, then rupture, then decide to go home with rupture protocol that we have, and come back and then deliver, and you feel like you've gotten to really know the family and through the process. Does that help answer your question, Adrian?
Yeah, I was kind of coming at it from the opposite angle of just if having residents spend all that focused time on managing laboring mothers makes them a little more conscious of managing labor toward successfully doing vaginal deliveries versus.
Yes. So, and to answer your other question, so we have a supporting physiologic birth group that was that one of our residents was involved with. This is not a hospital that's particularly C-section oriented. We do, because we do about 150 to 200 deliveries a month, seasonal variations can be quite a bit. the nullip singleton vertex rate can go anywhere from like as low as 5 or 6% to as high as 25%, and really like 3 cases can pivot that. So for those of you that don't know, there's like a hospital C-section rate, and then there's a C-section rate for those people that really should deliver normally or vaginally. So if somebody's had 3 prior C-sections and we do a C-section, we shouldn't really be counted as a high C-section rate for that delivery, because that's appropriate. So the nullip singleton term vertex rate is the one that we really pay attention to. And we really want it down in the low teens. Anything lower than that, and you start to worry about pushing it too far. And so, but that's kind of the goal. And that's the goal of the hospital and the labor management team and the midwives and the residents. There's no struggle there. That's a team effort.
Great, thanks, Gabe.
Thank
I'm
you.
glad you bring up the issue about the trying to get a delivery done so you can go home and get paid. I think and though that's not the case with us, I think it really demonstrates how our incentives are aligned with optimal patient outcomes, and is very patient centric. I'm glad you highlighted that. There were a question from, I think Gabriella and Angela both asked the same question about how often are residents primary on C-sections. You answered that earlier. Angela and Gabriella, do you feel like that was answered to your satisfaction? So okay, I see a head shaking, so I'll take that as a yes. Jacob's question about how many deliveries on average, I think we got that one. Joelle, I think we're going to have to hold your question about working with acupuncturists. We have an acupuncturist at our medical center, at least one. I also saw another question from somebody else about, is there a chance for residents to learn medical acupuncture? Not necessarily within our curriculum. I think with utilizing some elective time, you could certainly get some exposure and get yourself started down that pathway. But that to become a medical acupuncturist is an entire field of study. And I think out of respect to that field of study, I wouldn't think that you could get too far along while also training as a family medicine resident. So I would think of it more as an exposure and maybe a little bit of a jump start if you're going to think you might do that later in your career, but not becoming proficient in it as a family medicine resident.
Those trainings are quite robust and require a time commitment that would be, I think, would be challenging when you have 6 weeks of vacation as a seasoned doc somewhere. Pretty tough, I think, with a resident schedule.
Yeah, this one would probably be better for Sarah. A question from Pablo about a little bit more about the OB in the context of global health. I think as it currently stands, at least with our residency's involvement, it's been focused around also training and trying to support OB practitioners in developing countries to reduce maternal child death rates and training them in some of the modalities that we have around also. I don't know, I can't think of any residents that have gone abroad and done OB, but that's certainly, your elective time is up to you. And once the pandemic is behind us and we can do global health rotations again, if we have a resident who has a site in mind and it's clinically worthwhile and a safe site, by all means, that could be something that a resident would be very welcome to do. Tristan's question about addiction care, I think we answered that. I'm going to try to focus on the questions. I'm going to go a little bit out of order, just full disclosure here, and focus on the questions that Gabe could answer. Actually, maybe there's not any OB questions that are sitting here. Amanda, do you want to ask your question about the adolescent health outreach?
Yeah, so I didn't write it entirely what I meant, but I know you were kind of separating obstetrics health from kind of general women's health and gyne health. So what I'm curious about is kind of the outreach in adolescents and what is going on kind of like with reaching out to the local school systems and kind of.
Yeah, well, we have a
Yeah.
very close partnership with the Vallejo City Unified School District and have based our whole community medicine research curriculum around that relationship, and have developed a number of programs at the Vallejo, mostly at the high schools, both to help support the teachers and to support the students. And we had one residency class that did a research project around STI screening rates, and then rolled out a quality improvement program within our residency clinic to try to get at a reduction of STI rates in Solano County, where we are. Right now the schools are all virtual and there aren't students on campus, so our work in the school-based health clinic is essentially on hold. A lot of the work with the around the community-based research has become more research right now because we just can't access those students. It's just a reality of the pandemic. Most of the experience in our residency is all back and functional, with all of our rotations intact. It's just some of these community partnerships where these other groups just aren't either available for us to engage with, or some of the clinics aren't fully operational. Along the lines of adolescent, maybe they're like slightly post-adolescent, but we also have a medical scholars program that runs through Napa Valley Community College and Solano Community College, and the idea is to support underrepresented medicine students in pursuit of healthcare careers. It's run by one of our faculty, Dr. Ruben Gonzalez. That is very much still ongoing. I don't know if 18 plus is adolescents or not, but I think I'll count it. So that's definitely in effect. Let's see. Okay, Haneen had to leave. I think does anybody have any burning questions about OB or women's health we have probably just a couple more minutes here to be respectful of everybody's time. But any questions to pose to Gabe Flaxman, Dr. Gabe Flaxman, before we start to wrap up?
I do have a question just about how high risk of patients, or how complicated of patients do family med docs care for?
Thanks for asking, and I think I had seen that in the chat, and it slipped through. So thank you for persevering. Our medical center is a level 2 nursery, so we try not to deliver anybody below 34 weeks if we can help it, and 35 for multiples if we can help it. So we're not dealing often with a PPROM at 24 weeks that's about to deliver, unless they're really about to deliver. And I think it's really good training for family medicine in that way. I mean, I don't think that family docs really need to be juggling, triplets or quads on antepartum for 3 weeks until they deliver. But we have a very high risk in the kind of normal category. So lots of preeclampsia, lots of diabetes, lots of complicated social situations. We don't have the, addiction service like some places maybe in Seattle, and a couple other places in the country that are that kind of organized around family medicine. But there's also, because of the way, as Ted was getting to, the way that our system is structured, there's no financial incentive for somebody to take care of somebody. We just do right by the patients as a team. And so if the family physician is comfortable, so Sarah, as you guys could probably tell, is quite experienced. So if I'm on with Sarah and she wants to do a vacuum, that's totally fine with me. I kind of reserve the last pull just so that if I have to do a C-section, it's my own fault. But there's other family docs that maybe aren't as comfortable doing vacuums or managing, type 1 diabetic. Then I'll manage their insulin and let the midwife or the family doc manage the labor. So the residents and the family docs really do manage a significant amount of higher risk obstetrics without that kind of tertiary care or like TV stuff that is probably not something you're going to see after residency, other than stabilizing transport. So if that answers your question.
So
Yeah,
I'd
that
like
was
to,
great.
thanks,
Thanks.
Gabe. What I'd like to do here, there's a question from Harini about incorporating integrative medicine into practice that Matt Simquick, our Associate Program Director, answered, but I'd like to just put that out there so Matt can provide even some additional context and let everybody see it. There was also a question that it looks like several people wanted answered about the scope of abortion training. We actually covered that topic in quite a bit of detail in our session on women's health procedures 2 weeks, I think it was 2 weeks ago, and recorded it. So it's on our YouTube channel, and it's through that same Sway email that all of you have gotten. Well, actually, for those of you who've interviewed with us have gotten that. Actually, I think everybody got it at the beginning. You can access that video there and get an answer. We could also see at the end, I just want to make sure we're respectful of everybody's time and staying on topic, and I'm not dismissing that question at all. I want to get you the full answer. And it's like, I've heard Gabe, I was on that session, it's about a 5 to 8 minute answer, I think, to really paint it in full context. So I want to give it the attention that it deserves and point you in the right direction to actually get a really thorough answer. Harini, do you mind, before we consider getting into the other question, asking that your question about incorporating integrative medicine, and we can let Matt kind of give some context to that?
Sure. Yeah, my question was for the residents or former residents who've gone through that integrative medicine curriculum, how have they been able to incorporate the skills that they've learned through that curriculum into their practice, and how has that like enhanced their care of patients?
Can you guys hear me okay?
Yes.
Excellent. Good evening. Harini, thank you for the question. As you heard from Dr. Jones, from Sarah, many of our graduates, about 50% to date, are making a point of learning integrative medicine, and all of the ones that have made it a point integrated into their practice, I think quite freely, right? To the more specific answers to date, none of our graduates have specifically gone into a more integrative medicine practice, per se, but many of them I could think of, multiple grads from the last couple of years, really frequently work with their patients on herbs and supplements and vitamins and acupressure, and Caitlin with OMT, and all kinds of examples of it. Kaiser, I'm going to kind of integrate. There was another question about pain management that I think we could probably kind of integrate. So Kaiser has a multidisciplinary pain management clinic actually in all of our medical centers, and many of our residents choose to do some of their elective time in the multidisciplinary pain management clinic that we have. In addition, there are some examples of integrative medicine clinics within Kaiser in Northern California. Particularly South Sacramento has a really excellent interdisciplinary integrative medicine clinic for multiple things, for chronic pain, for intestinal issues, for female pelvic pain. They serve many different types of patients in their clinic, and we have not had a resident rotate there yet, but we certainly could. One of the many options that we have, just being Kaiser Permanente, Northern California, and being integrated with the other medical centers as well.
Great, thanks so much, Matt. Again, wanting to be respectful of everybody's time here. Gabe, regarding the question that you had about abortion training, do you think it's, I can kind of wrap us up and leave, and for those who want to step off the call and let you answer it after we stop the recording, or we can,
That's fine.
or we can refer people to the video. Like I'm happy to do whatever you think is the best way to approach it. I mean, the intent here is to get everybody's questions answered, but I also want to focus on.
Well, I think we should be respectful of people's time who need to go. And if I get another knock at the door, then I have to go. But I think I can give a couple minutes, as long as you understand that if it's short, it's just in the interest of time and not emphasis. So if people aren't interested and you want to sign off, that's fine. I'm going to give a kind of quick family planning overview. So our program is opt-out. Our default is that we don't believe that somebody should use all their elective time to provide something that, the vast majority of patients and families will experience is an unplanned pregnancy, and what to do with that. Our focus is a little different than many programs. So you may have looked, if this is a really important thing to you, you may look at the READY program or RAP, or Med Students for Choice, for the programs that are READY programs. And we're a READY affiliate because we don't take their grant money. So we're an affiliate, and we collaborate quite a bit, and have worked together with our local READY programs. We just don't need the grant money, so we're not part of the program. Our focus is also on medication abortion. And the reason is that in practice, the vast majority of family docs that provide abortion care do med-ABs. And especially as the evidence is pushing further and further in terms of gestational age, that becomes more and more of a possibility. The logistics around doing procedures in the office can be somewhat daunting, just from a workflow and supplies and ordering and that kind of stuff. So our goal is competency in med-ABs for everybody. We're in the process of integrating medication abortion into our family medicine clinics. So, well child, knee pain, cough, phone visit to rule out COVID, abortion, well child, just part of your day. And the goal is because it's just part of family medicine. So we have exposure for DNCs with a goal of exposure, and for those that want it, we have plenty. I mean, we haven't had a resident that's really wanted to pursue this to tap the opportunity, but we do procedures in the office for terminations, for first trimester once a week. We have twice a month, we have a block in the OR for second try and more complicated procedures that residents are welcome to join and encouraged to join. That's going to be more participatory, but not to competency for a 23-week procedure. A couple interesting things that I think we do is we have a prospective contraceptive workshop and pregnancy intention process. So I can get a report of all of your patients who are reproductive age, who haven't had a tubal and aren't currently pregnant or desiring pregnancy. And you can do outreach and say, hey, this person had said that they were really interested in Depo or an IUD or an implant, and then COVID happened and they never came back. And then you can actually do some outreach and say, hey, do you want to come back in, or what are you thinking now? And kind of starting to think about pregnancy intention as preventative care in the same way we might address any other preventative care concept. Not to say we're pushing birth control on anybody, but we certainly wouldn't want somebody to miss the opportunity for the birth control they wanted because we put a barrier in the way. So we train all our interns in Nexplanons and IUDs in July, so that if you have a scheduled patient in July, you know how to do it. We do a lot of postpartum Nexplanons in the hospital. We're doing some more post-placental IUDs. In our system, it's not as necessary because we have a pretty good comprehensive follow-up. But for patients that want it, we absolutely do it. For patients that want to wait, they can wait. And IUDs, I think most people are feeling comfortable when they graduate, if they're so inclined. Those that aren't interested aren't getting numbers because they don't want to. Nexplanons are fine. And then miscarriage care we're doing in our procedure clinic in the Family Medicine Center, as well as in Women's Health. So I think that's kind of the crash course. That's a little short. I'm sure I forgot something. I don't want to keep you guys late. If you have questions about it, check out the other Zoom recording, or email me is fine.
Great, Gabe. If you don't, I want to respect your inbox, but you can maybe drop your email into the chat so anybody who's interested can have it. And we can also like readdress. We're going to have a general Q&A towards the end of the at least when we're done interviewing. So there's an opportunity to also get some more context to any of these topics a little bit later on. So thank you all for your investment of time and certainly for your interest in our residency program and family medicine as a specialty. We hope that we will see you again, either at another virtual open house or in one of these other settings as we try to support all of you in your decision-making process through this very challenging interview season for all of you. So I wish you all a good evening, and we will see you again soon. And thank you, Gabe.
Yeah, of course. Good night.